Let's please welcome Dr. Sheryl Vondracek. She is an associate professor in the Department of Clinical Pharmacy at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. Dr. Vondracek has been teaching at the School of Pharmacy and practicing clinical pharmacist in the internal medicine at the University of Colorado Hospital for the past 25 years. She started when she was 5. One of her main areas of expertise and interest is pulmonary medicine, and specifically in COPD. So please give a warm welcome to Dr. Vondracek.
All right. Well, I'm excited to be here today to talk to you guys about pulmonary medicines. I've been a pharmacist. I've been at the university for 25 years, but I've been a pharmacist for over 30 years. So I get really excited to talk about medicines. Now, I realize not everybody is as excited as me about medicines. And it can be a kind of a dry topic at times. But I'm hoping that you can glean some pearls from what I'll be talking about today. And then, so again, I think just like the other talk, I'll just kind of go on and on and on. And then at the end, we're saving all the questions. Okay? All right. Next slide. So this is kind of a roadmap of what I'm going to be talking about over the next approximate 45 minutes. I'm going to talk about inhaled therapies for COPD and asthma. And then I'm going to talk about inhaler devices. So specifically going over some kind of tips or some challenges with those devices that it would be helpful to know about. I'm going to talk about innovative inhaler technology. So the last talk was a lot about wearables and that kind of technology with your smartphone. I'm going to talk about how we can connect innovative devices to your inhalers that can then connect to your smartphone and give you good information. So I'll talk just a little bit about that. Talk a little bit about oral and injectable medications that are used for COPD and asthma. Just one slide on vaccinations, which I know was also covered. And then I'm going to talk about just 2 therapies for pulmonary fibrosis. So I apologize to those that have pulmonary hypertension that are here today. I did not incorporate that into my talk. And so I won't be talking about specific therapies related to pulmonary hypertension. Okay, so my first thing I'm going to talk about is reviewing inhaler therapy. Okay, so again, you may know a lot about this already, but hopefully, again, you can glean some pearls from this. Next slide. So the first category I'd like to talk about, and there's going to be multiple categories that I'm going to talk about, is the inhaled bronchodilators. So what is an inhaled bronchodilator? That is a medication that is going to relax the muscles around your airways to help open up those airways so that you can breathe better. So that's what a bronchodilator is. So they really work to help decrease your work of breathing, help decrease your shortness of breath, help work with air trapping because they open up your air so air can't be as trapped into your lungs, and that's the hyperinflation that you can get with your lungs. Helps with exercise tolerance, and some of the medications that I'll talk about do some other things. The long-acting ones that I'll talk about also have been shown to help reduce your risk for having an exacerbation of your disease. So they do more than just help with your breathing in the short term. Okay, next slide. So we have short-acting bronchodilators and we have long-acting bronchodilators. Now, the short-acting bronchodilators work really fast. They work within about 3 to 5 minutes. And that's considered your rescue inhaler. So you should have that available with you wherever you go in case you need it to manage your acute shortness of breath. So if you're having an attack of shortness of breath, you need to have that on hand. It's going to work fast for you. You really should only be using these as needed when you have those issues. If you're using it every day, then your health provider really should be sitting down with you and looking at ways they can maximize your controller medication or your long-term medication to keep you from having to use that on a frequent basis. If you're using it a lot, it's usually an indicator that your medications aren't maximized, okay? The effects only last about 4 to 6 hours, so if you were going to use it on a regular basis, you'd have to use it pretty frequently, which is very inconvenient. So luckily, they developed these long-acting bronchodilators, and we call those, which we'll get to those in a minute actually, the long-acting are your controller medication. Those are the medications that you take every single day, the same as if you take your medication maybe for hypertension and you have to take a pill every day, or for whatever other condition you have. The inhaler's the same way. The long-acting ones are the ones you take every day. They can take a little while to work, up to 20 minutes for most of the long-acting bronchodilators. So it's not something you want to grab when you are acutely short of breath, because it's going to take too long for it to work. But the great thing is it lasts 12 to 24 hours, depending on the product, so you only have to take it maybe once or twice a day. There are some nuances about these long-acting bronchodilators with COPD versus asthma, okay? In patients who have COPD, we frequently use these long-acting bronchodilators alone. So you could just be on one long-acting bronchodilator, and that's completely appropriate, in addition to having your short-acting for emergencies. In asthma, however, we never use the long-acting bronchodilators alone. They always have to be used in combination with an inhaled corticosteroid, which is the most important med in a patient with asthma. So just keeping that in mind, that you should not be on one of these alone if you have asthma and only asthma. Next slide. So there's going to be a lot of tables that I'm going to have. A lot of this is really information for you to have in your handout. I'm not going to go over all the information, but the tables are pretty much organized the same way. I have the agents that are within this grouping or class, and then I'll have typical dosing. This is dosing and how it was approved through the FDA. So you may not be on this dosing, but this is where the majority of people would be on, this type of dosing for it. I have the devices where this particular medication comes from, and I'll be talking about those devices. So they're abbreviated, like DPI is dry powder inhaler, MDI is metered dose inhaler, nebs are nebulizers, so you can get a feel for these come in different types of devices as well. And then lastly is side effects, okay? So that's the one I want to focus on first for this. So this particular table is your short-acting beta-2 agonist. We call those SABAs, S-A-B-A, SABA. And that is, again, your rescue inhaler. It's going to work fast, but it doesn't last that long, okay? There's a whole bunch. Albuterol is a generic name, and there's a whole bunch of different brand names that you can get related to that. And then there's levalbuterol, which is another generic name and a brand name associated with that. The side effects that you get with a short-acting beta-2 agonist are things like being jittery. You're going to feel like your heart racing. You might feel some tremors in your hands, some nervousness. You can also experience a little bit of a cough after using it. It's more common when you're using dry powder to have that cough. Maybe some throat irritation might happen when you use that inhaler. Trouble sleeping if you use it too close to bedtime. So all those are side effects that you can see when you're using a beta-2 agonist, okay? But the great thing is people usually develop tolerance over time to that, so it's not as bothersome over time. It's only when you kind of first start using them that there could be a problem. But anytime you experience side effects, and they are bothersome, you should always talk to your health provider about it, because they have ways to help you manage those side effects. We don't ever want you stopping your medications because of side effects when there's things that we can do to keep you on those medications, okay? All right, next slide. That's just some pictures of the different types of short-acting beta agonists that are out there. You might recognize one that you're on, that you have. Let's see, actually, you have to go back one slide, I think. Yeah, so we missed this slide. So this is the other short-acting bronchodilator. It has a different way it works. It's called a muscarinic antagonist. So it does the same thing in opening up your airways, but by a different way, okay? And we call that a SAMA. So we have a SABA, and now we have a SAMA. And there's only one drug that falls into that category, and the generic name is ipratropium, brand name Atrovent. We don't see it used very often. It's sometimes used in combination with the albuterol, and they're used together. And I'll talk about that in a little bit. So it's kind of a rare thing. But the side effects that are associated with a muscarinic antagonist are different than the side effects you get from a beta-2 agonist. So the SAMA side effects are different than the SABA side effects. The SAMA side effects are dry mouth you can experience. It's a big one. Bitter taste when you use the inhaler. For the dry mouth, you can just use like sugarless candy and things like that, suck on that if that becomes an issue. You have to be cautious if you have narrow angle glaucoma, which is rare, but if you have that, you shouldn't be using these. And then it can sometimes cause a little bit of constipation. That is something you can see, but it's very rare, but be watching out for that. It's more common with the longer acting, but again, still very rare. And then if you have problems with urinating, and in men, if you have an enlarged prostate, then it is possible that these medications could cause problems with initiating urination. So it could have problem with that. Majority of the time, it's not a problem, but it's just something to kind of keep in the back of your mind if you're experiencing that, to talk to your healthcare provider about it. Okay, next slide. So now those are the pictures, because the Atrovent's on that picture as well. So these are the different types of short-acting modulators, just so that you can kind of make a picture to think about what I'm talking about. Next. All right, and this is a combination one. When I said they come and used it frequently in combination. So we have an inhaler, and this is very common. We're going to have a lot of inhalers that we're going to talk about where more than one drug is in that inhaler. And in this one, you have a SABA, short-acting beta-2 agonist, with a SAMA, a short-acting muscarinic antagonist. So two different mechanisms of action, two different ways they work to open up your airways. But they're both short-acting. So they work fast, but they don't work that long. Okay? So you may see those sometimes used, again, in combination for acute shortness of breath. The more you see these used, we see these in the hospital all the time. For our hospitalized patients who come in who have an exacerbation of asthma or COPD, then we use the combination of these two together in a nebulizer to help with their shortness of breath. Okay? And so the side effects are just going to be, for those two products together, you're going to could potentially experience any of those side effects from either of those drugs. All right, next category is the LABAs. These are the long-acting beta-2 agonists. Okay? Again, we call those LABAs. And these are the ones that are your controller medications again. So this is the one that as a COPD patient, a patient with COPD, excuse me, you may be on this by itself. But the patient, if you have asthma, you should not be on this by itself. You would be on it with another medication. There's two drugs on this particular list that are inhalers. They come in an inhaler form, Ceravent, salmeterol, and from, olodaterol or Straverdi. And two of these drugs that are nebulized only formulations. Whoops, back up again. These are the same side effects that you can see with SABAs. So the short-acting beta-2 agonists and the long-acting beta-2 agonists have the same side effects. Okay? So this is the same list that was on the short-acting one. Throat irritation, cough, your heart racing, feeling jittery, shaky, stuff like that. But again, you're using this one every single day, either once or twice a day, depending on the product. You're going to develop kind of, I said, tolerance, where you don't experience those side effects as much anymore. Okay? Next one. These are pictures of the long-acting beta-2 agonists. The Ceravent comes in a discus. The Straverdi Respimat, it's in a Respimat device, and I'll be going over these devices. And then the two nebulized products. Next. You sure I want to wait to the end to ask questions? Just it seems like wait to the end. Okay. Okay. I just want to make sure, I don't know who's on what or if you have additional questions, but please jot it down. If I was going through a particular product category and you have a question about it, please jot it down so you can remember to ask. The next category is dual bronchodilator, long-acting. Okay, so this is where we combine the long-acting beta-2 agonist with the long-acting muscarinic antagonist, so LABA and LAMA, together in one inhaler. So you only need one inhaler, but you're getting 2 bronchodilators in one inhaler, so 2 different ways to open up your airways in one inhaler, which is great. Okay, these are really only used in patients with COPD. They're really not used in patients with asthma. Okay? The products that we have are all inhalers. They come in different types of devices. We have Anoro Ellipta, and I'll be talking about that device. We have Stialto Respimat. Said I'll be talking about the Respimat device. Bevespi Aerosphere, if any of these sound familiar. Duoclear Press Air. These are all the products we have that are combination dual bronchodilator inhalers. And again, the side effects are going to be the same side effects you get with a long-acting beta-2 agonist and a long-acting muscarinic antagonist. So LABA, LAMA side effects at the same time. Again, rare. A lot of these side effects are rare. And this is just pictures of the different products. Okay, next slide. Next category is inhaled corticosteroids. So that works a little different than the bronchodilator. It opens up your airways, but it does it by decreasing inflammation and swelling inside your airways. Okay? One is relaxing muscles. That's what a bronchodilator does. The inhaled corticosteroid reduces the swelling and inflammation inside the airways. Okay? The inhaled corticosteroids, for the most part, and I'll give you an exception when I get to it, are considered controller medications. Again, medications that you need to be taking every single day, just as if you would take a pill for a particular condition. So it's just the same. And so they should not be, again, except for one circumstance, and I'm giving you an exception, they should not be used as a rescue. Okay? And really, we don't use inhaled corticosteroids alone in patients who have COPD. If you have COPD, you should be using the inhaled corticosteroid along with a bronchodilator. Okay? If you have asthma, the inhaled corticosteroid is the most important medication for you. Now, you could be using it in combination with other things, but you have to be on an inhaled corticosteroid, or we really try to make sure that you're on an inhaled corticosteroid. Okay, next. There's a whole bunch of these. Okay? So again, we have fluticasone, a whole bunch of brand names associated with that. Budesonide, Pulmicort is a brand name for that. We have beclomethasone, mometasone, celestazone. So we have a lot of different inhaled corticosteroids that you might be on in different products. Okay? And again, the dosing is very highly variable depending on your condition. And then the devices, again, are listed there. Now, side effects are going to be different for an inhaled corticosteroid than they were for the beta-2 agonist or the muscarinic antagonist. So these side effects are different. The biggest side effect that you can get with an inhaled corticosteroid is a yeast infection in your mouth and in your throat. And that is we call it thrush. Okay? And these white plaques that you can develop that can be painful in your mouth. But the great thing is you can prevent that by every time you use that inhaler that has an inhaled corticosteroid in it, you have to rinse with water, rinse around in your mouth and spit that water out after each use. Okay? And so that'll prevent that from happening. But if you do notice it happening, again, please contact your health provider about it so that we can do something to keep you on the inhaled corticosteroid even though that is happening. Other things, easy bruising, some hoarseness also. And in patients more with COPD, this has been seen. With certain inhaled corticosteroids, there is a small increased risk of pneumonia. So now the pneumonia outcomes are still very good, but it's a very, very small increased risk for pneumonia. It's more with certain types of inhaled corticosteroids than others. And so it's possible that if you have you develop pneumonia or multiple episodes of a pneumonia, then it might not be a good idea for you to be on an inhaled corticosteroid if you have COPD. But that's rare that we have to take people off, but that's something to keep in mind that can happen. All right, these are some different types of inhaled corticosteroids pictures to kind of, again, put inhalers to mind. Only a couple more categories, and then we'll get into some other stuff that I find more fun. But this is a combination of inhaled bronchodilators with a corticosteroid, okay? So the great thing is, over these years, they have developed these inhalers where there's more than one product inside, more than one medication inside the inhaler. So you get 2 or 3 medications in one, which is great. So here's an example of a beta-2 agonist, long-acting, in combination with inhaled corticosteroids. So these could be used in patients with COPD or in patients with asthma frequently. So they work by both mechanisms. So you're going to get that bronchodilation, you're going to get relaxing of the airways by reducing the tightness of the muscles, and then you're going to get the decreased inflammation inside your lungs. So you get 2 mechanisms to help open up your airways so you can breathe better. And again, all of these medications that are long-acting have been shown to reduce your chances of going to the doctor, to the emergency department, or the hospital with an exacerbation of your disease. If you use them the right way and use them continuously, they've been shown to do that and help that. These are considered controller medications. Again, things that you take on a daily basis, except there's one exception, and that's something unique for asthma. So those of you who have asthma, there's something called MART, M-A-R-T. That's the maintenance and reliever therapy. So there's one type of a medication that can be used for both as a reliever and as a controller medication. But that's specific right now to asthma. Next slide. Okay, so we have your long-acting beta agonist with your inhaled corticosteroid, and we have various products for that. The one on top is brand name Symbicort, fluticasone with budesonide. That's the one inhaler that's unique in that it is used in asthma. It's considered MART therapy, maintenance and reliever therapy. And that's because the long-acting beta agonists in that particular product, formoterol, is unique and it works fast. It works fast but lasts long. So it can work within about 5 minutes, but then it lasts a long time. We also have a lot of information in asthma to say that if you are having an acute episode of shortness of breath or acute worsening of your condition of asthma, taking an inhaled corticosteroid at that moment also is helpful. And so you can use that combination product as your maintenance medication and as your reliever medication. So that's unique, but that's the only one that's approved to do that right now, and that's the only one the guidelines recommend to do that with, is that particular product. The rest of them, you have salmeterol, fluticasone. Some of you may be on those products, Advair, Wixela, Airduo. There's a whole bunch of different brands for that. There's formoterol with mometasone, Dulera, Vilanterol with fluticasone, Brio. Those are all different brand names. Okay, again, the side effects of these are going to be similar to the side effects that you see with either of those products alone. And because it has an inhaled corticosteroid on it, you want to remember to rinse your mouth out and spit after each time you use it to prevent the development of that thrush, that infection. Another unique product at the bottom of that slide, just go back a second, is something that's pretty new, again, specific more for asthma. It's a combination of a short-acting rescue beta agonist with an inhaled corticosteroid together. And that's a pretty new product that can be used for asthma, for a rescue inhaler in asthma. So it has both the steroid to decrease inflammation and the quick-acting rescue medication. Okay. And again, here are some pictures of the different inhalers, if you recognize maybe one that you're on. All right. This is the last category of inhalers, and that's your triple therapy. So this one has dual bronchodilation. So it has 2 different mechanisms to open up your airways. So it's got LABA and a LAMA, and it has an inhaled corticosteroid, all in one inhaler. So it's all three in one inhaler. And actually, one of the inhalers I'm going to talk about, it's made to handle 4 meds. We just don't have 4 meds to put in it. We only have 3 right now. So it's great. It's nice to be able to get all of that if you need it. And in many instances, maybe one inhalation once a day, and you get all of that. You get anti-inflammation in your lungs, the swelling, and the relaxing of your airways all at once. Brands are Trelegy Ellipta and then the Breztri Aerosphere are the brand names of the drugs that have all 3 of them in there. And again, side effects are going to be the same as all the individual components. You have the potential to get the beta-2 agonist side effects. You have the potential to get the muscarinic antagonist side effects, the dry mouth and constipation, that kind of stuff, and the inhaled corticosteroid side effects. But again, the doses that are used, it's very, very low likelihood that you'll get those types of side effects. Okay. And those are the pictures of those inhalers. All right. So that's that. That's all the different products. Now I want to talk about the different types of inhalers that there are, okay? And I do have my little box of tricks here that I brought along with me. But the first category I'd like to talk about is meter dose inhalers. And so I have a few of those here. I've got actual in my demo. Here's my demo. So basically, meter dose inhalers are the ones that look like this for the most part. They usually have a counter on the back of them. This is Ventolin as an example. But there are some other medications, not just the short-acting beta agonists, the SABAs that come in the meter dose inhaler, but we have a lot of other medications that come in meter dose as well. And so you can always refer back to that slide to see if that particular medication comes in a meter dose inhaler. This one is Flovent. This is an inhaled corticosteroid that comes. It has a counter as well. So the things about, next slide, the meter dose inhaler that I'd like to point out is there's good things about them. There's challenges associated with every device, and there's tips that I want to give. But the most important thing about any device is, one, you need to know how to use it correctly. And so you need to be educated. It's not easy. I have to teach my students. That's one of the things I do, is teaching them how to educate patients on how to use these. And it's challenging. It's hard for us to use these. And so it's okay, and you should be reinforcing this every visit you go to the doctor or your health provider. Your pharmacist should be reinforcing how to use these correctly, because they're not easy. I wish they were. And if you have any questions about any of these, obviously, feel free to ask me. These are portable, which is great. So as a rescue inhaler, really easy. You want to, put it in your purse, put it in your bag, make sure you have it with you wherever you go. It's not dependent on how fast you can breathe in. That's what we call inspiratory effort, or inspiratory, peak inspiratory flow. So how fast you can breathe in doesn't matter with these, because it's a propellant that is used to propel the medication into your lungs, okay? So that's good. Now the challenging things about these types of inhalers is they have to be primed. So what that means is when you've used it for the first time, or depending on the product, there's certain restrictions on how long, if you haven't used it, you have to prime it, and every product is a little different. But if you haven't used it for like 3, 5 days, things like that, depending on your product, you have to spray it out away from you, a number of sprays it tells you to prime it, okay? And what that's just doing is allowing for that medication to kind of clear up that little pathway so it's not clogged. You don't want to use it and then not get a good amount of medication because it's been sitting for a while and you don't have good flow. So this helps get good flow going. And there's extra inhalations in these to account for priming, so you're not losing your medication. The other thing is it does require hand-breath coordination, meaning if you're using it without a spacer, then you have to be able to breathe and push at the same time. And that timing is important to be able to get the medication into your lungs. And that can be challenging for some people, having that timing right. You have to remember to shake these. These have to be shaken. So you really want to shake it up to mix up the medications with the propellant. So you have to shake it. They should be cleaned once a week so that they kept clean. And for most of the inhalers, you're going to need to be able to hold your breath after a dose. Okay? They usually say up to 10 seconds or as long as comfortable for you. So if you can't make 10 seconds, don't try to make 10 seconds. Do whatever is comfortable for you. But you do need to hold the dose to help it get deeper into your lungs and make it stay there and not just come right back out again. Tips, you can use a spacer with these to help make it easier to use. So I don't know if people have used a spacer before. So this is a spacer, an example of one. So the device just goes in the one side, and then you don't have to worry about the timing of pushing or actuating the container and breathing, because you can push it and then breathe in. So you don't have to worry about that timing because the chamber will capture it for you. Okay? So that's kind of nice. You can use that. The other thing about this one, I have to remind you, if you are storing it somewhere, for women in their purse, for men, maybe in a briefcase, wherever you put it, make sure one of the very important thing is when you take this cap off, always look inside and make sure there's no dust or items in there. Now, we don't have as many pennies around as we used to in the day, so people probably don't have pennies in their purses and stuff. But a good friend of mine had a hair tie, a little tiny hair tie in hers, and unfortunately it was in there, and guess what she did? She inhaled it. So it's really just a good thing to quickly take a look and make sure there's nothing in there before you use it. Next slide. Again, more pictures of the different inhalers. Next. And then again, the spacer. This just talks about the spacer, that you just follow the instructions on how to use your meter dose inhaler. Along with this, you still have to rinse your mouth and spit if you're using the steroid product that's a meter dose inhaler. You still have to do that. You do have to clean these. That's another thing that you have to do. And some of them, and I'm not exactly sure, this one might whistle to let you know if you're going too fast. It's really a slow, deep breath that you need to take with a meter dose inhaler. Okay, next. Dry powder inhalers, a whole bunch of these. Okay, so I've got a lot of different products that are considered dry powder inhalers, and I'm going to kind of pull out here. Some benefits of these, they are portable, so they are all small and can be carried around, so that's nice. They don't require hand-breath coordination, so you don't have to worry about the timing. When you breathe in, that's when you get the dose, and it's usually a quick, deep breath that you need to do with these. So inspiratory effort is important for these. So when you're breathing in, the medication's getting into your lungs based on your breathing effort, how quickly and how deeply you can breathe in. Okay, so that's going to be important. We need to make sure that you're able to use that appropriately and take that good deep breath to get the medication, not to deposit in your throat and in your mouth, but deep into your lungs. Okay? Doesn't require any priming, which is great. So you don't have to worry about if you haven't used it for some reason. These are your maintenance medications. We're hoping you use it every day, and there's no gap in using it. But if for some reason you haven't been able to use it, you don't have to worry about priming it. There's no clogging that happens because the medication becomes active when you open up the product. And so there's no medication around until that point in time. Okay, this one's an Ellipta device here. Because it's a dry powder inhaler, it is affected by moisture. Okay, so you don't want to store this in any area where there's high moisture. Okay, so that's one thing that you have to remember about these, is they are affected by moisture. Two, you don't want to shake it or breathe into it. Once you've opened that up, you've punched a capsule or done something to the device to release that medication into the chamber for inhaling. And if you tip it, you shake it, blow into it, it's going to disperse the powder and you're not going to get your dose. Okay? So that's really important with any of these dry powder inhalers, not to do that. You will have to hold your, You'll have to hold your breath. These usually have an expiration date for them once they're opened. And so either you have to write it on there or your pharmacist can help you write the expiration. Each one has a different expiration date. When you're inhaling these, many of these have vents. Now, if you can see the vents on this one, you don't want to put your fingers over the vents when you're using this, okay? Because that would impair the ability to generate the air that's going to flow to get the medication into your lungs. So these dry powder inhalers really are these small particles of medication that are mixed with a loose carrier, a thing that's going to carry them into your lungs. And it's usually lactose that is used as a loose carrier to carry this medication. And that's your inactive ingredient, your ingredient that doesn't do anything, but helps get the medication to your lungs. So if you, for some reason, have a severe milk allergy, we're talking an allergic reaction to milk, not intolerance to milk or lactose, but an allergic reaction to it, then you wouldn't be able to use some of these products because of the lactose in it. But most people do not have true allergies to milk, but some might. Let's see, what else is there? Oh, you don't always feel this. When you're using a meter dose inhaler, there's a mist, there's a spray that you can feel. You might not feel this, but that doesn't mean you're not getting the dose. Okay, so you don't want to take another one. You don't want to close it and reopen it and say, I don't think I got it, and take another one, because it's just how they work. They don't always feel them. Here's another example of another one. This is Wixella. I don't know if anybody's on Wixella. Very similar. This is how this one looks. Just activate the dose by pushing that down. It's got a counter on it. It's got vents too that you don't want to cover. And then here's the Trudorza press air device. This one's kind of neat. When you breathe in, it changes from green to red to show that you got your dose. So this has a little kind of neat little thing there. All right, so those are all my little dry powder inhalers. And those are some pictures of them. Next. Okay, capsule ones. All right, so this one is, here it is. I don't know if anyone's on this. This is Spiriva. Comes in a HandiHaler device. Okay, so this is unique, and that's why I'm talking about it separate. Because there is a generic now available, and the device looks very similar. It's called a loop inhaler instead of the HandiHaler. But it comes with, the medication is in a capsule, which is separate than the inhaler. So it's a little bit more challenging because it's not quite as portable in the sense that you have to remember to bring your capsules and your inhaler with you everywhere you go. Whereas on the other inhalers, you just take your inhaler, everything's all in here, you don't have to worry about it, okay? And there's like a lot more steps involved with this as far as having to put the capsule inside, which can be sometimes challenging. It's this little capsule that you gotta open up, you can't puncture it, you gotta peel it back, gotta drop the capsule in, which can be challenging, then you gotta push this button, which can be hard to push, to pierce the capsule, and then you inhale. And then you inhale twice from this to get the full dose of the medication. So again, you don't wanna tip it, shake it, or anything like that, because once it's pierced, that capsule the powder is ready to be inhaled. Okay, so there's just a few extra things involved with using that particular type of inhaler. The good thing is you don't have to worry about moisture because the capsule's sealed inside here, and so it won't get affected by moisture like the other inhalers could. All right, next. All right, soft mist inhaler. This is my favorite. I don't know why, but it is. So this is the Respimat device. We only have one soft mist inhaler, so it looks like this. Okay, so this one is, it's not a chemical propellant that propels the medication into your lungs. It's spring-loaded and pressurized. That's what causes the medications to get into your lungs. So that's unique. And it's not dependent on how fast you can breathe in. Those dry powder inhalers, again, we're really dependent on getting that air so that, was that only 5 more minutes? Holy cow. Okay, I gotta go faster now. Some of the challenges with this thing is it does have to be primed, kind of like a metered dose inhaler, it has to be primed. So that means, again, spraying it into the air the first time you use it, and it has to be assembled. You have to put it together. So your pharmacists are more than happy to help you with that and show you how to do that. But it comes with the cartridge separately, and you have to put the cartridge in to get it going. It does require a long inspiration time. So it takes about 3 seconds for that spray to get out. So it takes a little time for you. You have to breathe in for that 3 seconds. Let's see. You need there's some dexterity or strength needed to twist it. So top is what we use to describe how to use this particular thing. That's turn, open, and then press. And it's important to do it in that order. Turn, then open, then press. You can see that air coming out there. So it takes a little time for that. This is a demo. But again, turn. That can be, maybe hard for certain people. Open, and then press. You don't want to go turn before, and then open and then turn, because sometimes people have sprayed it in their face. Because sometimes you can accidentally hit that button while you're turning it. So it's important to do it in that particular order. Okay? I think there's 2 inhalations always, usually from these products, and so you don't have to wait between. You can just go ahead and do them. All right, next. Nebulized medications, some benefits of those. Easy to use, no hand-breath coordination needed. You're just relaxing and breathing at your normal pace while using it, which is great, but it's not dependent on inspiratory effort. You don't need to hold your breath. That's the one you don't have to hold your breath afterwards. It is covered by Medicare Part B, which is a good thing too. It takes time though to administer the medications. It could be up to 15 minutes. It's not as portable, dragging the nebulizer with you places. There's not as many medications available in nebulized formulation, and sometimes they're very expensive. The long-acting ones are very expensive. And they require cleaning, appropriate cleaning, and you have to be on top of the cleaning so that it can be safe to use. Next. Okay. Oh boy, innovative technology. So I'm not going to be able to get through anywhere close to the amount of stuff I thought I was going to be able to get to today. So innovative technology, this is kind of similar to what Dr. Vanderveer talked about, but this is from the inhaler device perspective. I don't have any examples to show you, but it's really these sensors that you can purchase that can go on your inhalers. And then these sensors communicate with your smartphone via Bluetooth. So this signal. And it can do a whole bunch of different things. And there's several different companies who have made these sensors. Propeller is one of them. On the next slide, there'll be Haley, and you can go look these up. And those 2 companies have multiple different types of sensors that can go on a lot of different kinds of inhalers. So the Ellipta device, the MDI devices, the Respimat device. And what it can do is it can track your usage, remind you to use it. It can, in some instances, tell you maybe you weren't using it correctly. Maybe you didn't shake it like you were supposed to. Things like that. It can give you tips on how to use it better. So there's a whole bunch of smart technology out there now that links with your smartphone or your phone. And so you can have an app downloaded on your phone that takes all this information, and it can communicate to your provider too. And your provider can see that information as well. If you guys have your hand out, you can kind of turn. The other 2 are just are inhalers that you can buy where the sensor is incorporated into the inhaler. And so that could be covered by insurance. That's Digihaler. That's a product that different things come in that. There's a short-acting rescue medication that's a Digihaler. There's an inhaled corticosteroid that's a Digihaler. So it has a lot of different products, and again, does the same kind of thing, but it's in the inhaler itself. And so when you get a new inhaler, you get another smart inhaler, okay? That one, again, would be covered by insurance, and it's all together. Page 7, I don't know, you guys have a different slide set than I do, but slide 42 is, I was going to talk about some oral medications for COPD. So oral steroids. And I guess the down and dirty on that is that we try to limit the amount of oral steroids that people get, okay? Because they have side effects. They have bad side effects. And so people who've used oral steroids know that. Now, used in short term to help you with an exacerbation of your condition, they're great. They're very important. They're essential. but we don't like people to be on them long term because of the long-term side effects associated with them. Short term, you can get some insomnia, you can get some jitteriness or nervousness with them, you can get some increases in your blood sugar, you can get some increases in your blood pressure. Long term, there's some other bigger side effects that we get worried about with being on long-term steroids. So we try to minimize the dose as much as possible, or try to use these inhaled steroids instead. Anybody on theophylline or hear of theophylline? So theophylline is also one of those ones we rarely use anymore. It's an oral tablet. It's a bronchodilator, so it opens up your airways, but it's got a lot of challenges with it. It's got some side effects. Pardon? It's probably hard to get. Nobody really wants to, it becomes a challenge when a drug becomes generic and people don't use it very often for a company to want to make it. And so that becomes very challenging, and things that should be inexpensive become very expensive, which is also a challenge. But you have to monitor your blood levels to make sure that they're okay. And there are some side effects. If you go over a certain level, you can get some pretty significant side effects. There's drug interactions with it. So if we can avoid tablets and stick with inhalers, they're a lot safer in our patients. God, I cannot believe it took me this long to get through all this.
Do you want to go to some questions, Cheryl?
let's do
you
some
want
questions.
Do we have any questions in the room?
Yeah.
Okay, I'm coming.
Hello.
Hello.
It's your local friendly hygienist yet again with all of the questions. One thing that I wanted to circle back to that you had said about the dry mouth being a side effect of a lot of the inhalers. For any patients that are currently doing that, what I'm recommending is a mouthwash called TheraBreath. It's over the counter, ugly bottle, orange lid, can't miss it. Works really, really well. Second, I also use another dry mouth spray. If anybody's interested in what I use personally, because I have medication-induced dry mouth, that's something that I actually brought with me because I carry it with me everywhere. So that's just to prevent any type of dental issues is my focus. So stay away from sugar, please, as I have a giant muffin in front of me. Next, sorry. Back to the ipratropium. I have a lot of patients that are still on that. Is that something that I should probably have them talk to their pulmonologist about, maybe looking into some of the newer medications?
So if it's ipratropium just alone, it is something that it's not inexpensive. So it's, you think that maybe it's been around for a really long time and it would be inexpensive, but as an inhaler, it's actually not very inexpensive. And insurances should be covering the long-acting products so you have to take less often. Ipratropium has to be taken, if you're using it as your controller medication, every 6 hours, which is a long time, a lot to have to use. And the data with the long-acting ones in showing reductions in exacerbations and things like that is so much better. And so yes, if possible, there may be a reason why, but it's always a good thing to ask, is there a way to switch to a long-acting product? Yes.
Awesome, thank you. Sorry, I have another few questions. Back to the medication that causes possible pneumonia. Have you seen an uptick in issues with the COVID pneumonia and having to pull patients back off of it due to damage from long COVID?
Let me see if I understand your question correctly. So the inhaled corticosteroids you're referring to?
Yes.
And having to take patients off because of long COVID?
Yeah, like the patients that have had issues with pneumonia or any type of long-lasting effects with lung damage.
I can't say for myself that I have seen that, and I don't know if Dr. Vanderveer can comment on that. I would say that for patients who have COPD, the inhaled corticosteroid is very important once you get to the point where you're having a lot of exacerbations and you have something called elevated eosinophils in your blood. Those patients seem to respond really well to inhaled corticosteroids. If you don't have the elevated eosinophils in your blood, the question is, could you do without the inhaled corticosteroid? And then it's a risk-benefit balance. far as long COVID, I don't know if people are being taken off for that reason. Multiple episodes of pneumonia is a risk benefit in saying, I don't think that benefits you enough for the risk of pneumonia that you're getting. But from a long COVID perspective, I am not familiar with that data.
Okay, thank you. My last question. I'm sorry. I'm not sorry. I need to know this stuff. So back to the thrush issue. Are we educating patients on prevention of thrush when they're initially given the RX? Because a lot of times I'll have patients come in. I see thrush every day in my practice. So I'm just wondering if that's more a pulmonary rehab that we're talking about it, or the pulmonologist actually checking the oral cavity to see if there's active thrush going on?
Well, I'm a pharmacist, so anytime a pharmacist dispenses these medications, they should be talking to patients about how to use them. Does that happen? Probably not as much as it should, which is unfortunate because of shortages in the community pharmacy setting. They don't always get to educate patients, or they may get their medications through mail order or things like that and don't have the opportunity to talk to them. But any health provider who's interacting with a patient on an inhaler should be reinforcing those important tips and reinforcing how to use them correctly.
Hi. I use Symbicort with Spiriva, but I take the Spiriva at night. But listening to what the effects, would it not be better to be taking that in the morning, not at night?
So the question, if you guys heard that, can you take Spiriva morning or night, is pretty much asking. Spiriva is supposed to last a long time, so it should last 24 hours, okay? So it doesn't, and if you take it every single day, you should have consistent amounts in your body, okay? So most people take their inhalers in the morning, but it shouldn't matter if it's working well for you, taking it at night. It shouldn't affect your sleep. It's not one that's going to affect your sleep.
Okay.
It should last throughout the day, so it should be fine. Doesn't have to be taken in the morning. It's never said that you have to take the inhaler in the morning. But I would say majority of people do it that way.
But would it not be better in the morning, because then it has a higher concentration level in your body, and therefore it's obviously more use to you when you're more active than at night when you're sleeping?
Yes, I mean, it takes about, again, 20 minutes to start working, but you're going to have certainly some kind of an increase in the amount at that time. Inhalers aren't like this and then they drop. So you're going to have more of a smooth kind of a picture to it, and then you should, before you go too low in that drug, you take another dose. And so you really shouldn't have these big peaks and big troughs, I call them, big ups and downs with that medication. But yes, when you're more active in the morning, it would probably be better. But if you feel like it's working for you at night, then that you don't have to change it, but you could try it and see, does it work better for me giving it in the morning?
Yeah, fair enough. Thank you.
Any other questions?
I'm standing between them and food.
Yes, you are, Sheryl. Yes, you are.
Yeah, I'm doing the Delera and the Pro Air. How much do you have to shake them?
That's a good question. Usually, I would say like 4 or 5 times, and that's good.
I sit there for a minute or so shaking. It says shake well.
Yeah, it's, you don't have to do it that long. So a few seconds of shaking is going to be good. I mean, most people probably don't even do that, but you should do that. You should, not a whole minute you have to shake it. That's not necessary. So let's say,
4 times?
3 seconds, 5 seconds or something like that of shaking it.
And I was also told that do the Pro Air, the rescue inhaler, first thing in the morning, because that gives you a quick thing from not being without it all night. Is that right?
Again, people have nuances in how they like to manage conditions, and if that works for you to do that and it helps you more, to use a short-acting first thing in the morning to open up your airways, and that works for you, then that's how you're being prescribed it. Typically, the Pro Air is, again, a medication, a rescue medication that you use when you need it for shortness of breath. And so we do try to, use those less often and try to maximize the medications that you're on that are your controller medications like your Dulera.
I don't feel like I need it, so stop doing that.
Well, I would have a conversation with your health provider before you stop doing anything and just say, hey, I'm not sure I'm seeing a difference with this. Should I keep doing this or not? And have that conversation. Okay. There may be a reason, and if you bring it up, you guys can talk about it, the reason behind it. And maybe they go, yeah, sounds like a good plan. Let's take a break from it and see how you do. But always have those conversations with your health provider, because they may have a reason that you're not aware of for doing something. And that opens up the dialogue.
We have time for one more. Is there anyone with a burning question for Sheryl?
I have a burning thing that I want to tell you guys. It's the last thing on my slides that I didn't get to, and that's disposal of unused medications. So do you see that last slide? So if you have a whole bunch of unused medications sitting in your house, you need to go to this website and find a deposit box where you can get rid of those. It is unsafe to have unused medications in your house. And it's not safe to flush them down the toilet. Can it be put in the garbage? Only if you put it in a sealed container with like coffee grounds or kitty litter or something. And even then, if there's a safe box, and there's a ton of them out there in pharmacies and various places that you can deposit these, please get rid of your unused medications. And you can dump your medications into a baggie and throw them in there, but just make sure if you throw away or recycle your bottles, make sure your information is scratched out of them. Either take the label off, rip it up, or black it out so your information is on the label.
Thank you, Sheryl. Can we give Sheryl a round of applause? Thank you so much.